Welcome to this podcast episode dedicated to pediatric asthma, how to make a diagnosis. Today we are discussing how to make diagnosis of asthma in children after the significant updates from November 2024 of Joint Guidelines on Asthma Management in Children, developed collaboratively by BTS, NICE, and SIGN. To discuss this topic, we invited Dr Yanny Delgado, current asthma clinical co-lead for children and young people Asthma Network in Norfolk and Waveney. She is also pediatric consultant at Queen Elizabeth Hospital, King's Lynn, with expertise in respiratory medicine and allergy. So Yanny, tell us a little bit about your path working with asthma and why this topic is so important.
So, hi, Vala. Thank you for the invitation to join to this podcast episode. I started as pediatrician 20 years ago. And from the very beginning, I love respiratory conditions, especially these conditions that have like a chronic presentation, because I was always curious and conscious about the high impact on children's and families' quality of life coming from that conditions. It has been always called my attention how asthma can vary its presentation through patients' lifespan. I mean, how asthma can sometimes be very troublesome with several acute episodes and very limiting for the daily activities as playing sports or running around. That is very usual, activity during the childhood. And how some children present with mild symptoms and another one just present with recurrent acute episode. Taking this in account, I have learned how much the level of knowledge that the patient, the family, and the healthcare team supporting these patients needs to have regarding the asthma condition. It makes a huge impact on their successful management. So I found these recent UK guidelines from BTS, NICE, and SIGN are a good national steps to homogenize and simplify for healthcare team aspects of asthma diagnosis and treatment in children. We must remember, Bala, that there are many factors that influence how an asthma patient achieves optimal control of their asthma. It starts with principles as making an accurate diagnosis, selecting the appropriate pharmacological treatment, but also it requires that clinicians provide education to patients and families and how those inhalers work, and that treatment needs to be given. Also, what kind of triggers the asthma has and how to manage an acute episode. It starts from the identification of the episode until they are completely or successfully managed, or how to escalate for seek advice. There are many different guidelines with different recommendations before. So these 2024 UK guidelines are a very good first step to support a wider use of those principles.
So Yanny, tell us more why there was a need for a unified guideline.
Yes, this one guideline or unified guideline approach replaces this fragmented guidance. I mean, there will be a mainly clinical approach from BTAs and also the approach from NICE to be cost efficient. So, and also this guideline is aligning with Gina's recommendation that is a guideline that was evidence focused. So having all these three components in this new one guidelines is very good, yes, for the clinicians. This one guideline focuses on effective treatments. It also incorporates specific UK evidence, particularly in the management of the eosinophilic inflammation and the use of the combination inhalers as needed. The benefits of having this one guideline is to bring consistency and efficiency. A single national guideline ensures that the healthcare professional across the UK provide consistent and effective care, promoting a unified approach to diagnosis and treatment. It also improves diagnosis. The guideline introduces new diagnostic strategies and tests, like FeNO, the fractional exhale nitric oxide, and blood eosinophil measurements alongside the traditional spirometry. All of these help to increase the diagnosis chances and accuracy, especially for eosinophilic asthma that is very frequent in children. It indirectly empowers primary care settings with more tools to confirm diagnosis when there is a clinical suspicion. The guideline also brings better management. New recommendations of these guidelines are aligned with GINA's principle, particularly in the use of these combination inhalers that are inhaled corticosteroids plus formoterol inhalers that are used for maintenance and reliever, so the patient has only one device. This early introduction of MART, yes, and the new approach of AIR, this anti-inflammatory reliever therapy in children and young people, is one of these novelty from this guideline. All this approach with this guideline will support the evidence and reduce severe asthma attacks and hospitalizations. And it also has a very important message. It shifts away from relying solely on SABA, the short-acting beta agonist as reliever, as well as acknowledging the limitations of a single gold standard test for asthma diagnosis.
Perfect. So, Yanni, for the first time, BTS, NICE, and SIGN have come together to produce this comprehensive UK-wide guideline for asthma diagnosis and management across all age groups. So, clearly a big step. But let us start with more details about the new guideline for pediatrics patients. Diagnosis asthma in children has always been challenging. Is this guideline making this easier?
I think in a way the answer is yes. The guidelines enhance the roles of the diagnosis and give clinicians clearer recommendations, the steps and the tools that they can use to achieve that diagnosis. And also it start to recommend to be used from early age, yes, when it's clinical based, and from a kind of diagnosis objective testing when they are over the age of 5. So it definitely, I think it helps.
And do you want to explain this in more details, please?
Yes, of course. There is a data that approximately or nearly 500,000 children and young people in the UK show in a GP records an asthma diagnosis. It makes a prevalence around 10.2%, yes, of children in 2018. It has increased, all these numbers has increased over the last previous decade. However, there is evidence of both over and under diagnosis of asthma in 30% of the cases from data coming from adults and children. This is especially problematic in preschool children where objective testing is more difficult. So overdiagnosis can lead to unnecessary medications use, and side effects coming from the medication also has another effect, and is the banalization of the condition, while underdiagnosis may delay the effective treatment with inhaled steroids, and it will put the patient, yes, in a risk to suffer attacks that could be avoided. In fact, delayed diagnosis was cited as a major factor in asthma-related deaths in 2014 National Review of Asthma Deaths. The new guidelines recommended the use of FeNO testing as the first-line diagnostic for children aged 5 and over. A FeNO level measurement will be over 30 parts per billion or higher, and it will support an asthma diagnosis. If that FeNO testing isn't available or is not showing that level, the next step will be to go to an spirometry with the bronchodilator test or bronchodilator reversibility, and a number over 12% will be suggestive of asthma. That will be also then to use if you don't have any of them available or any of the previous tests mentioned were negative. The clinician will have the option to do the peak flow variability when a value over 20% is suggestive of a diagnosis of asthma. The next step on the new guideline is about the measurement of blood eosinophils on a patient with increased total IgE. So all of them made as the 4-line tool when appropriate. All of them might be used, yes, with children with high probability of asthma based on their findings on the clinical history. I found, Bala, that is very important because children can have limited access to objective testing. And it is limited because of the age, for example, in children younger than 5 years old, when even if the objective testing or the tools are available, is not often feasible, yes, to be performed because of the capacity for them to perform these tests. But there is, in this group of patients, the high probability of asthma, it will be meaning that there is the use of the clear and structured clinical history of asthma symptoms. There is also a confirmation of finding of wheezy on that auscultation. And in many of them, the response to the salbutamol after that evidence of wheezy, they will be very suggestive of asthma or given high probability. They will be also important in patients to roll out, for example, a trial of ICS. In that special group of age, in younger than 5, you will be able, as has been done so far, to try a low dose of inhaled corticosteroids and for approximately 8 to 12 weeks, then to be able to recheck the treatment response and be conscious that treatment will require to stop the treatment for a while to see if the symptoms are coming back, and that will be diagnosis of asthma. It's important also in pediatrics that we will have the asthma control tests or the asthma control questionnaires. They are validated tools to measure, yes, the impact of this treatment. So that is very important to use. If you want, I can just give an example. So, for example, a 2 years old with recurrent episodes of documented wheezing in the physical examination, who is presented with nocturnal cough, of symptoms when the child is very active or when the child is laughing, and there is no other symptoms that suggest an alternative diagnosis. That child, in our current guidelines, we can start a trial with beclomethasone and a low to medium dose, and it can be given, of course, twice daily with the appropriate training for that device, with the use of the good inhaler technique, check, and of course the parents has been checked how to use appropriately that spacer, and doing an emphasis on the adherence that is required for the carers to continue that treatment. The trial is considered successful if the symptoms has stopped. So the medication then is suspended, and in the next 3 months, there is observation that the symptoms come back again. That will be a diagnosis of asthma, and then the plan will be to come back to the treatment that has been proposed to control the symptoms and trying to titrate the minimum dose to achieve that. If the trial fails, so there is no improvement of the symptoms, or there is an uncertainty of that diagnosis, a referral at that point to secondary care, yes, is when is advised by guidelines. I would like to highlight that if the symptoms persist when the trial is started, it's very important to give like a step back. It's important to assess again the inhaler technique. It's important to assess the adherence and also to review the environmental factors, yes, like housing conditions, smoking exposures as possible triggers, if we are consistently thinking that is asthma. If not, that will be the first step to say, I look for an alternative diagnosis or consider a specialist referral. The guidelines are very clear about all these tools might be used in patients who has a clinical presentation of asthma. It also encourages to start coding a diagnosis of asthma earlier than before, using the term suspected asthma. Meanwhile, the diagnosis is being established or the tests are being performed. In that way, the child or the patient gets the benefit or already being established in pathways designed for primary care, as for example, the annual asthma reviews, where diagnosis is always reassessed and the patient benefit to have a close and regular monitoring. It also allows the suspected diagnosis from very early age to keep ongoing the reviews in when the child reaches the 5 years of age, that objective diagnosis then will be available for that group of age.
So it looks like the first message of how to make the diagnosis in children and young people is using a very structured history taking, looking for clear symptoms suggestive of asthma, and looking for examination of bilateral wheeze that has responded to salbutamol use, and prescribing and inhale corticosteroid as a medication response trial in younger than 5 years. The same approach in terms of a robust clinical history suggestive of asthma, plus requesting objective testing in form of FeNO or peak flow meter or peak flow variability, spirometry, or blood testing for eosinophilia finding to achieve diagnosis in older than 5-year-old. So, what else are the guidelines updating?
Yes, the guidelines are giving new options of management of asthma from younger than 12 years old and consideration on how to escalate the treatment. Easier if the treatment is not being effective. So let me explain a little bit this in detail because it can be confusing. So for children aged 5 to 11 years old, the guidelines emphasize starting treatment for newly diagnosed asthma with a twice daily low dose inhaled corticosteroids alongside a short beta agonist SABA as needed. It translates, for example, the common use of beclometasone, Clenil in young children, well known by parents as a brown inhaler, to be used with a good inhaler technique twice daily, in addition with the prescription of the blue inhaler, the salbutamol. This short beta agonist is called by parents and patients. Of course, if the child is older enough and can manage a DPI, so this formulation that is a dry powder, yes, device, and that generally is given in children older than 8 years old who are able to manage, yes, this technique, and so they don't need an spacer. In that case, the first option will be a device, yes, that can provide that formulation. So if asthma control remains inadequate, so this ACT, this asthma control test, is less than 20, or the patient is presented with asthma attacks, persistent symptoms at night time, or persistent symptoms when he is having exercise, the next step is when the guidelines start to be different from the oldest BTS version. At this step, the clinician is going to choose between two options. The first one is to already follow that conventional pathway. In that case, will be go steps ahead to do the low dose of ICS and combine with the long beta agonist or LABA, yes, and using salbutamol as needed in case of symptoms as reliever. For example, these combinations when the ICS and LABA are these known devices as the purple or white by patients, so commercially Seretide, Conbilsile as examples. Prescribing the SABA or blue inhaler is just for the reliever. In the guidelines, you also have the options, yes, as previously known, to add a montelukast or another kind of leukotriene receptor antagonist. For persistent symptoms is when the clinicians can choose to go a higher dose with the same combination ICS LABA as recommended. And of course, the low dose to moderate dose can be seen in the guideline or in the BNF for children. And if they don't achieve control on that step, and that group of age is when a specialist review is advised. But the new guidelines is having those new alternatives to start to use the maintenance and reliever therapy as an option, as the first step, or air therapy. So I will explain a little bit more. So to prescribe maintenance and reliever therapy or MART, low dose will be the first step. And if the symptoms still are not controlled on that patient, the next step will be to increase the dose but continue on MART. And if you don't find that the patient is responding, is when you just refer to a specialist in pediatric respiratory medicine. But just want to clarify, Vala, a little bit more about what exactly MART means. Like I said before, is maintenance and reliever therapy. Is when the patient doesn't need it's when the patient is using the same inhaler that will provide the maintenance dose as a combination of ICS with a LABA, yes, or a modified LABA, and it replaces also and is used for the reliever. This therapy is very attractive because it's delivered via a solo device. And unfortunately, one of the limitations with the guideline is recently not many formulations has been licensed for children, and most of them are formulations so there are no any of them the smart formulations given via PMDI device. So that is this conventional inhaler that is frequently L-shaped, that requires some propellant to deliver the medication and requires being used by the spacer. So most of the MART devices currently in the market in the UK are these dry powder inhalers, this DPI, which deliver the medicines as a dry powder rather than in a spray, and is breath activated. So it means that the child might be able to take a quick deep inhalation to activate and use it. So in some of the children, it can be very challenging. And in young children, and especially if the child has some difficulties on learning the technique, it can be also very difficult for them to get used to the use of these devices. So it restricted that population on this therapy. It's important also to remember that the MART is the combination of the ICS and formoterol. Formoterol is not a lone beta agonist at itself because it also has action that is very short. It starts to do a very fast, and the onset of the action that bronchodilator is also very fast. So that is why this medication or this MART can be only be used with when the formoterol is part of that device. It cannot be used with a conventional. So it's important to don't get confused of any kind of combination inhalers can be used for MART. There are dedicated inhalers and devices specifically for them. So being again, coming back to the guidelines, one of the non-negotiable conditions to choose the new option of treatment suggested by the guideline is to choose the correct candidate for the alternative treatment. A child between 5 to 11 years old needs to be able to activate that DPI. So you need to use the 4Cs, yes, when you are prescribing an asthma device. You need to choose correctly the DPI that is available. Yeah, so there are different formulations available. And you need to be able to check that the patient understands the technique, be able to correct and confirm that the child will be able to use that inhaler.
So, Yanni, please allow me to interrupt and ask more details about this new change. On previous version of BTS guidelines, the MART option was for children over 12 years and adult. Why is it changed? And is this easy to implement in younger than 12-year-old?
That's a good question, Bala. You are right. There is evidence that the maintenance and reliever therapy is more effective in reducing exacerbation and improving daily asthma control. And it has been already evident in older than 12 years old. There are current studies for younger, and especially in UK, for younger than 11 years old. So that is one of the things that we need to continue supporting these studies to get more evidence. There is also evidence that the use of a solo device to treat acute symptoms that can be also used for the daily maintenance is very relevant for increasing adherence. A real problem on asthma management. Yes, many of the main situation why, or the main reason why the patient is no control is because the patient doesn't follow, yes, the treatment with the regularity that we will expect him. But what are the guidelines now suggesting the use of these devices or this therapy in younger people? It is known that asthma trials and guidelines often do not distinguish between adolescents and younger children. For that reason, the National Heart and Lungs Institute at Imperial College London studied the influence of age on clinical characteristics, pharmacological management, and exacerbations in children with asthma. They analyzed the medical records from primary care and secondary care of 1,119 children with asthma in England from 2004 to 2021. The study included approximately 60,000 children between age 5 to 8 years old, 32,000 between age 9 to 11, and 25,000 young people aged between 12 to 16 years old. The study looked how the asthma changed with age, including how likely participants were to have an asthma attack or to have a delayed diagnosis, with the researchers defined as receiving asthma treatment before they receive an asthma diagnosis. So that study found that the group of children between 5 and 8 years old were most likely to have an asthma attack. These 14 of these children had an attack in every whole year, compared with the 7% of the children among 12 to 16 years old. The study also found that the delayed diagnosis was most common in youngest children. And young people aged 12 to 16 were less likely to receive both long-acting preventive and short-acting relievers. 1 in 5 used short-acting relievers only for 2 years. So all these findings highlight the need to start to talk of treatment and alternatives of optimization in younger children than 12 years old as previous guideline recommendations. So the publication of these new guidelines in 2024 has brought this shift in the emphasis away from conventional treatment, a different inhalers for maintenance and a different inhaler for acute symptoms, and shift toward a reliever therapy, the same device for children for maintenance and the same device to relieve the symptoms, especially in children with no controlled asthma after the first step of a low-dose ICS, or the inhaled corticosteroids. Although this approach is welcome due to the MART association with better outcomes and reduced exacerbation rate, there is a lack of evidence of dosing and safety in that group of age. There is a lack of familiarity for the healthcare professionals and patients with that regime, and the lack of availability, particularly of that group of age, of licensed device. So all these challenges and the implications to be brought to the real world is part of these new guidelines are bringing. There are clinical trials in this group of age, as I said before, to bring more evidence that can give us the evidence that we need to have. But until these trials are available, the guidance, yes, is clear that how to ensure a safe care for children and young people with asthma and all levels of care is definitely needed. The Beat Asthma Group and the Primary Care Respiratory Society has published documents that outlines a consensus recommendation based on the base available evidence and expert opinion. So I definitely recommend to visit these websites and documents to familiarize with them. These kind of resources are with the aim to provide guidance and a safe approach within the limitations of the evidence in this group of age and with the limitation of the devices being currently available. It is very important because the formulations used for MARTs in this group of age are currently unlicensed. So it means that it's going to be off-label. So we are definitely waiting, and very, very soon that situation is going to change, and we will have more devices available and recommended via BNF to be able to prescribe. The most important consensus of these recommendations is the need for children to be regularly reviewed. So any change that you are doing in your patient or any kind of alternative of the treatment, the most important is to have a close monitoring of these patients. And that is an emphasis of these new guidelines. It also recommends that MART therapy is chosen and applied within the scope of the expertise and confidence of the clinician delivering the care. So that is why there is always the alternative to continue with the traditional approach of the treatment. And like I said before, it's very important when you are making the decisions to follow the guideline or to change the treatment in an asthma patient to consider the opinion of the child, the opinion of the family, and assess the ability of the patient to use the particular device that is being prescribed.
Okay, thank you, Yanni. You have described as the first change on management that has been recommended for the age 5 to 11 group of age. And can you please tell us what changes is bringing for the eldest group, 12 to 16 years?
Yes, of course. On this group of age, the most significant shift in the new guideline is to move away from SABA-only treatment. So remember, as I said before, there is evidence that there is over-reliance on reliever inhalers, the SABA, blue inhalers, salbutamol, and it has been linked to the poor asthma control, and it had also been associated to a higher risk of death. There is evidence that regular or frequent or excessive use of SABA is associated with an adverse effect due to decreased bronchoprotection. There is rebound hyperresponsiveness and decreased bronchodilator response. It is also associated to increased allergic response because increased eosinophilic inflammation due to the overuse of salbutamol. But how much is too much, you will ask, if you are prescribing? How can I know if the patient is using excessive salbutamol? So studies have shown that 3 salbutamol or SABA PMDI device per year, so that is approximately, on calculations, 1.7 puff a day, is associated with a higher risk of a presentation to an ED department because of an asthma attack. And more than 12 PMDI devices of salbutamol per year is associated with higher risk of death, nearly the double, yes, of the risk of death. Having this in mind, the guidelines now recommend the treatments with regimes that are able to address the both symptoms and underlying inflammation. So it brings in the new change on this group of age, and that is the treatment or the approach that is called AIR, anti-inflammatory reliever. It's an option of therapy for children who present with infrequent symptoms. So when I call infrequent symptoms in asthma, is symptoms that present less than twice a month, who also are in asthmatic patients who doesn't have any risk factors for exacerbation. So the main risk factor for an exacerbation in an asthma child is the evidence of any asthma attack in the last 12 months. It means that there is no room for children and young people older than 12 years old to be prescribed salbutamol alone anymore. Yes, and there's also evidence of these guidelines that you should be checking children with symptoms related with the exercise. So they can be the candidates to start if the patient is just having very, very occasional symptoms. Instead to prescribe the salbutamol as a solo, you can now prescribe a combination of ICS formoterol to be prescribed as needed by the principle of anti-inflammatory reliever therapy. It's also very clear that there are symptoms of asthma or need of reliever more than twice a month that air therapy is not the option. You need in that moment, and especially the patient has had a recent asthma attack, the prescription of that group of age should be go to MART. That is the step to follow.
Certainly, a relevant change for all, for patients and families, with a very clear message about the inflammatory nature of asthma, and for the healthcare professional for safer approach to the management of this condition. Yani, are the guidelines also emphasizing on education?
Yes, the guideline is supporting the concept of empowering patients through education. It is well known that education is a cornerstone of effective asthma management. As I said before, it's important that the family and the patient know the condition. The guidelines advocate for providing children and their caregivers with personalized asthma action plans, educations on trigger avoidance, and support for self-management. It also highlights the need for collaboration between the school and healthcare providers to ensure a consistent support for children with asthma. As we discussed today, the guidelines are changing a lot the conventional approach for the management of asthma in pediatrics populations. These new regimes, AIR or MART, all of them demand a personal asthma action plan. This might be the summary of explaining the children and the families the number of doses for those maintenance treatment, how the symptoms are in need to be identified, what is the frequency to use those medications. They are also these kind of as personalized asthma plans needs to be classified in different escalation zones. So how many maximum dose they can be used, yes, in one time, or how many dose in total on a 24 hours period. All that information should be contained on those documents. And it's important for the patient as well to learn how to seek medical advice. And it needs to be by written. So anyone who is supporting the children will know how to escalate.
All right. If there is any role for SABA prescription as part of those asthma plans?
So that is a great question because by guidelines, there is no role for the use of the salbutamol if you have been prescribed a device that is used for maintenance and reliever, or if you have been only prescribed that new device of the combination ICS for Motelor as an air therapy. There is one exception, and is if the child or the young person in the situations when they are in a MART regime, the MART inhaler is not available. For example, in the school, yes, so they forget. If there is an acute need of treatment, yes, the symptoms should be relieved with salbutamol, the conventional device, of course, with the appropriate spacer if the device demands one. So that is very important because it's still a gray area. If the patient is trained and know how to escalate the symptoms, the DPI device that is used for air and MART should be enough. But if the patient or the person who is providing the care is not familiarized and they got access to a salbutamol, that should be taken in account. It's important also, sorry, I would just say that the salbutamol remains like the way to tackle the asthma symptoms in acute healthcare setting. For example, any child presented to primary care with acute asthma symptoms, salbutamol will be, even if they are in air and MART, the first recommendation to tackle this exacerbation.
Thank you. Thank you very much, Yani. There is no doubt these updates represent a significant step forward in providing standardized, effective care for young individuals with asthma. And thank you all for joining us on navigating the 2024 asthma guidelines. We hope this helped you apply the new recommendation in practice.
Thank you, Bala. Thank you for